and welcome to EULAR TV. I'm Maria Sokolova from the University Hospital Schleswig-Holstein in Kiel, Germany, and today we are talking directly after the session EULAR Recommendations II with Professor Helena Marzo-Otega. Thank you very much for taking the time.
Hi Maria, thank you for inviting me.
It's my pleasure. You just presented the very much anticipated EULAR points to consider for the definition of difficult to treat psoriatic arthritis. And it was a lively discussion afterwards. And I also wanted to ask you a couple of questions. The first one would be, could you summarize what were the biggest challenges working on this task force that you led?
Okay, yeah, there were several challenges along the way, so thank you for asking. But one of the first ones was actually the title, the nomenclature, whether we really should be referring to difficult to treat as a main entity. Because once we realized that actually the subject was much more complex. There was a lot of nuance to it. So when we're talking about a situation in which, we have difficulties managing, there are a lot of things that we need to consider. So it's going to be, do we have presence of articular manifestations associated to psoriatic arthritis? Perhaps we're looking at a different type of condition. That's my patient has gout as well as psoriatic arthritis. And there are a lot of issues, pain, syndromes. Is there inflammation? Is there not? All these issues need to be considered. And then we realize that when we talk about difficult to treat, we're actually referring to the subset of patients or the situations in which we have uncontrolled inflammation. That's how we decided to change the terminology. And we went for treatment refractory scenarios when there is active inflammation versus difficult to manage scenarios when we do have a lot of other considerations, not necessarily inflammation. So the key really is, do we have inflammatory disease or not?
Thank you very much. And could you summarize for us what features define, based on this work, what features define the difficult to treat psoriatic arthritis?
So this treatment refractory scenario will be a situation in which we have a patient that has been through different biologic or targeted synthetic DMARDs, and we have put a cutoff of at least 2 different classes, because the whole idea with these definitions is to be able to conduct research in this area. And it may be that once we start with the research projects, we realize that we only need to go through one agent. Yeah? But so far, we needed to put some boundaries, and this has been all driven from the literature available to date. So it's the scenario in which people are unable to achieve a state of low disease activity as per current recommendations. They have been to at least through different drugs with different mechanisms of action. Both the patient and the clinician decide that things are not good and they're not well controlled. So that shared decision making should have come, high on the agenda. And we do have a scenario in which there is active disease. This may be summarized by a swollen joint count or by evidence of inflammation on imaging, either ultrasound in peripheral joints or MRI in the axial skeleton, or a high CRP. These will be the scenarios in which we are facing a refractory, clinical situation. And this will be a true difficult to treat or treatment refractory scenario.
Yeah. I also wanted to expand a bit on the clinical practice because I have a feeling that sometimes we see patients who have high pain levels.
Yes.
And we don't see clinically any inflammation. What would be your recommendation on how we objectify the disease activity in this?
So that's precisely why we're giving so many indications. I think at the end, all the considerations around how to assess non-response just provide us with a roadmap that we have to look at, that we can utilize in the clinic. So why is my patient not achieving that level of response? You need to always reappraise the diagnosis. Are we dealing with psoriatic arthritis here? Or could it be that we have a concomitant problem, such as gout or osteoarthritis or something else, yeah? And then, is there inflammation, is there not? And then we go into, if there is no inflammation, what may be causing that inability to achieve the response? Pain syndromes will be high up on the agenda. Comorbidities, some of them are pro-inflammatory, for instance, obesity. Is lifestyle factor consideration? Does my patient smoke? Smoking can actually perpetuate inflammation. So it's just how we think about the different scenarios in order to be discarding them. But one of the most important considerations is I would hate people to come out of this session or to read the paper once it's published and thinking, actually, is this a different disease? No, it's not.
Yeah,
This is a clinical scenario, and what we're trying to do with the definitions is we're trying to standardize the way we look at it, but the definitions are not meant to be applied in clinical practice. At the moment, they are meant to apply in research, and once we have the studies ongoing, we will know exactly the type of picture we're looking at, and we will be able to give more discerning avenues to apply in clinical practice.
And I'm hopeful about the future, that these points to consider, and in general that we will get better in treating difficult to treat psoriatic arthritis.
Absolutely, we're always hopeful. The whole point here is that we need to understand why are we not achieving that response, and what can we do to discern the reasons for that non-response, and in case address them, so we are able to give the right treatment to every patient at every stage. So this is not a label to be attached to a patient. This is a clinical scenario that is mobile and fluctuates. So you may have a difficult to manage situation when somebody wants to get pregnant, for instance, and there are things that we need to consider, but then we may be able to find the right treatment approach for that patient who is not going to be on the difficult to manage scenario any longer, right? So the most important thing is to take all these considerations into account, and is there an inflammatory problem? Is there ongoing inflammation that I need to do something about or not? Yeah.
Okay, thank you very much. That was very insightful. Thank you for
Thank
taking
you.
the time after the session. And to our audience, thank you for being with us at EULAR TV, and have the great rest of the conference, and see you next time.
Thank you, Maria. Thank you all.